Hey guys, Gary Peterson here. We are continuing on our pathway down the Universal Patient Assessment. Now at this point we have completed our primary assessment. We have a couple decisions to make. Did we have an issue in the primary assessment? If we did, and it required intervention, a significant problem, then the rest of all this happens en route. So you immediately mobilize resources and you can start your patient assessment. I mean, a lot of things happen simultaneously. What's going to end up happening is I'm going to start sending my partner for the cot, the backboard, any other special equipment that I need, and I'm going to start this now so I don't waste any time. But if everything was completely fine in my primary assessment, my patient's talking to me, they're breathing normal, yes, they were in a rollover MVC, but airbags deployed, no loss of consciousness, no blood thinners, all the safety mechanisms did exactly what they were supposed to do, and this guy's walking around outside the car being like, I don't want to go to the hospital. And you have checked everything. Well, now you have a decision. You can go ahead and just stay on scene and complete this secondary assessment, making sure that you have a good comprehensive review of everything. If, however, you actually had a problem in your primary assessment that required intervention, and it was significant, now your guidelines point you to the direction of do the rest on the way. So if they meet indications for backboard, we're going to go ahead and do that. If they meet indications for whatever, we're going to go ahead and do that and then keep moving at the same time. Doing this assessment, most likely finishing this assessment, at least the second half of it, while we're heading down the road. So let's get into it. First of all, an acronym that you're going to hear is DCAP-BTLS. That's going to be deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, and swelling. That's pretty much going to exist everywhere that we hit. And the one thing is it's going to be out of order. We're going to go head, trunk, lower extremities, upper extremities, and then back. If for some reason this patient met rapid extrication, because there was a major problem in the primary, so we're doing rapid movement, and they met an indication for long backboard, then as soon as the backboard's at the side, we're going to go ahead and roll our patient. We're going to check the back while it's exposed. We're going to roll them onto the board, and then we'll finish up the rest. So that'd be the only thing that comes out of order if you end up in that situation. Less and less patients are meeting indications for backboard, mostly because the backboard qualifications are coming down lower and lower. Okay, so we start. This patient, we've got DCAP-BTLS at the top. We need to make sure that we have appropriate BSI, gloves on, and we make sure that when we do the assessment, we have hands on the patient. So we're going to start at the top, and we come around the backside, checking for DCAP-BTLS, feeling all the way. We're going to look at the anterior. We're going to check the pupils, see if they're equal reactive to light. We're checking inside the nares, inside the mouth, and inside the ears. We want to know if there's any blood or CSF fluid, any indication of that. We want to make sure that the oropharynx is still stable and patent. And now we're going to move to the neck. Now, if you've already applied a C-collar, you're going to simply have a partner hold C-spine, pop open the C-collar so you have good full circumferential access to it. We're checking DCAP-BTLS, any step off in the back of the C-spine area. And in the anterior aspect, we're checking for sub-Q emphysema, GVD, and tracheal deviation. Now we expose as we go, and then we keep our patient warm, because trauma patients must remain warm. And I'm sorry, we are moving through a trauma assessment. We'll talk about medical secondary assessment in a minute. We're going to do the anterior chest here. We're going to put hands on. We're going to let them take a nice deep breath. We're checking for equal rise and fall, good chest excursion, any paradoxical movement, anything abnormal, as well as DCAP-BTLS here. And at this point, we're going to take our stethoscope again, and we're going to be listening to at least 4 positions. And here we're actually listening for quality of lung sounds. So we're going to do a breath, 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 and breath, okay, making sure that we get the anteriors and the laterals. And now we want to know if we've got wheezes, rhonchi, rales, diminished, clear, anything like that. We want to make note of those issues. We're moving down to the abdominal sections, and we go hand over hand, pressing just with the pads of the fingers, kind of a nice deep press, just in and up, in and up, in and up, all 4 quads. And we want to know if we have any guarding rigidity. We want to know if we have any distension. We want to know if it's scaphoid. We want to know also if there's any DCAP-BTLS in this particular area. We're going to go ahead and keep the patient warm as we move down. Brings us to our hips, okay? We're going to just press in and down at the same time. No more rocking, no more excessive movement in case the pelvis is stable. And that's what we're checking for. We're checking for, is my pelvis stable? If it's not, now they're going to need indications for a pelvic binder, and we can go ahead and prep for that. I'm going to sweep for priapism, and then we can move into the lower extremities, and we can check for decap BTLS down the one lower extremity, and then we're going to check for pulse motor sensory, decap BTLS down the other extremity, and check for a pulse motor sensory. Make note of any deficits, any issues there. Keep our patient warm, expose the upper arms, and we can check decap BTLS down both arms, check for pulse motor sensory, and they can give a squeeze on the hands, and if they're not responsive, you can squeeze the nail beds to see if you have any responsiveness there. At this point, we can go ahead and log roll our patient, sweep the back, make sure there's any step off, any decap BTLS there, and any notable changes. Now, that's our head to toe assessment under our secondary assessment. In addition to our secondary assessment, we have our sample, which is signs and symptoms, allergies, medications, pertinent past medical history, last meal eaten, and events prior to. We also have our OPQRST. That's a little bit more of a specific follow-up on a specific complaint. If you have multi-system trauma everywhere, then it's going to take you forever to get through OPQRST, so you're just going to hit the highs and lows. But if it's more of an isolated trauma, you're still going to review the patient head to toe and then circle back to the one major complaint. Say they mountain biker off their bike and they've got a dislocated patella. Now you're going to go into OPQRST much more specifically on that knee. And it's onset, provocation, radiation, severity, and time. So that can also be used inside your medical assessment as well. The final component into your secondary assessment is a full set of vitals. Your full set of vitals for a BLS operator is going to be the pulse, your respirations, your blood pressure, your skin temperature, whether at least you can at least note by skin to skin if it's going to be very hot, very cold. If you can get it numerically, bonus. You need to have your pulse ox. You need to have pain level, your highest pain level, and note what the location is. You also want to note pain levels on any other complaint areas to be able to track whether those change. And if it's within your scope of practice as a BLS operator to get a blood sugar. If it is, you're going to get a blood sugar every time. I cannot stress this enough. If you're an ALS operator, then all of those, as well as you're going to put the patient on an EKG, if it's appropriate, especially, it always is appropriate if it's multi-system trauma. If it's isolated trauma, it's going to be using your discretion. So that's your full set of vitals, and that's what ends up getting repeated. You don't necessarily have to repeat your baseline sugar. Everything else continues to be repeated every 5 minutes if the patient is unstable or predicted to be unstable. Every 15 minutes if the patient is stable. That wraps up our trauma secondary assessment. And what we're going to do is, once again, we're going to apply the principles of how we can smoothly move head-to-toe assessment. Those principles, we're going to be able to apply it to our medical patients. And that brings us into the beauty of the universal patient assessment. All right, guys, I'll see you on the next video. Until then, love, protect, and help.